Well, good afternoon, everyone. I think we'll go ahead and get started. I know that folks will be trickling in. I'm Deirdre Lyell. I'm a professor of Obstetrics and Gynecology and maternal field medicine and director of Perinatal Epidemiology and Population Health within the Dunlevie Maternal Fetal Medicine Center.
And I'm Suzan Carmichael, an epidemiologist and professor in Peds and OBGYN and co-directing this part of the center with Deirdre.
And we are so pleased to welcome you to the inaugural event, our first symposium within Dunlevie Perinatal Epidemiology and Population Health within that theme. The objective of the center has been, as many of you have heard to date, to rapidly expand and accelerate discovery in the science and practice of obstetrics. Yasser El-Sayed, who's on this call, is the director. The center has 4 domains. First, basic science discovery. Second, prenatal diagnosis and fetal therapy. Then there's clinical trials, obstetrical, medical, and surgical. And then finally, our theme, perinatal epidemiology and population health. Our center purpose is really to highlight and amplify ongoing research at Stanford so that we can build community in this area. We've been working to build relationships between researchers to bring attention to the multiple synergies that exist at Stanford, as we all know, and the extensive collaborations that also are out there and we're hoping to help build. We know that activities enrich each other, that we are all stronger, and that's one of the wonderful things about Stanford is that we are such a collaborative environment. We also want to emphasize the importance of connecting the themes of the center to each other, both scientifically and collaboratively.
So we're excited to really bring all this, these goals of the center to population health and perinatal epi in particular today. And basically the goals of the symposium are in line with the goals of the center to just learn about the variety of research in this area at Stanford in particular, and just bring us together and give us an opportunity to build community. And I'll just go over the structure briefly with you. So we're going to have 3 sessions, and then we'll have a breakouts after the 3 scientific sessions. There'll be a break in the middle, and we'll have a 10-minute discussion after each of the scientific sessions. And then, in the end, we'll do the small group breakouts. And then we have happy hour at Deirdre's home. So hopefully many of you can make it to that in person. And if you need any extra information about that, if you missed that by any means, we can put it in the chat, or you can email one of us and we can get you that information. And then, so Deirdre and I are going to switch off moderating the different sessions and keep us on time so that we can make it in time to the happy hour, because that's important. And then we'll keep, for the sake of staying on time, we're going to ask, you can put Q&A in the chat anytime, but we will just have discussion at the end of each scientific session. So we'll have a keynote and then 2 speed talks and then discussion. And then, so these 3 sessions are going to address, the first is observational research, the second is quality improvement and interventions, and then the third is community engaged research, and then the 4th is the breakouts. And then also wanted to just put a shout out for the MCHRI Community Engagement Conference, which is on October 20th. So I guess we're ready to begin. So Deirdre's going to moderate the first session.
Great, thank you. It is my honor and delight to introduce Dr. Brian Bateman, who will be giving the keynote for the first session, using big data to study the safety of medicines in pregnancy. Dr. Bateman, as many of you know, is professor and chair of anesthesiology, perioperative, and pain management at Stanford, or pain medicine at Stanford. Before he came to Stanford, Dr. Bateman served as the vice chair for faculty development and chief of the Division of Obstetric Anesthesia at Brigham and Women's Hospital, Harvard Medical School. Dr. Bateman's scholarship focuses on the study of medication safety in pregnancy and on predictors and management of maternal morbidity. He's published seminal work in this area, and we are delighted to have him give our first keynote talk. So Brian, the floor is yours.
Terrific. Thank you so much, Deirdre, and thank you, Suzanne and Yasser, for the invitation. I'm going to share my screen here. Oops. Okay. So this is the outline for the next 20 minutes or so. I'm going to start off by talking about why we study medication safety in pregnancy, why that's an important issue. I'll talk about some of the different designs that are available to study medications in pregnancy, and we'll take a somewhat deeper dive into the use of big data to get at these questions. I'll go through an example study that was conducted by our group looking at the safety of ondansetron, and then I'll briefly touch on some future directions. So why study the safety of medications? Well, medication use is incredibly common. Data from Medicaid patients suggests that a large majority of pregnant patients are dispensed at least one prescription medication during pregnancy. And various medications have been implicated in a range of adverse pregnancy outcomes, ranging from preterm delivery to preeclampsia, gestational diabetes, neonatal hypoglycemia, and postpartum hemorrhage, just to name a few. But an area that's of particular concern is the potential association between medication exposure and congenital malformations. Congenital malformations are a really important topic from a public health perspective. They account for a substantial fraction of deaths during the first year of life. They frequently lead to lifelong disability. And in fact, if you look at the number of disability-adjusted life years that are lost in association with congenital birth defects, it's a complication that's on the same order of magnitude in terms of public health impact as stroke, COPD, HIV/AIDS, or chronic kidney disease. And importantly, safety data on medications is really lacking. A systematic review looked at the 54 most commonly used prescription medications and then graded the strength of the evidence regarding teratogenic risk. And it found that in only 2 of the 54 most commonly used medications was there good to excellent data regarding risk. A further 18 had fair to good data, meaning that 34 of the 54 most commonly used medications, the quality of the data regarding their safety of use in pregnancy was graded as less than fair in quality. And this is important because it not only informs whether medications can be used in women who are pregnant or people who are pregnant, but in people who of reproductive age who may become pregnant. We know about half of all pregnancies are unplanned, and so there's concern if a patient's using a medication and inadvertently becomes pregnant, they may be continued to be exposed through the early weeks of pregnancy before the pregnancy is recognized or before the patient presents to an obstetrician and the medication can be discontinued. So how do we go about studying the safety of medications? Well, historically, a mainstay was the use of registries. And in this approach, patients are prospectively enrolled early in pregnancy, sometimes through information hotlines about the safety of medications in pregnancy, sometimes through enrollment at physicians' offices. And then they're followed throughout pregnancy. And once the infant is born, it's assessed, and that's used as a way of identifying risks associated with the medication. And while this approach is useful in identifying the strongest of teratogens, these designs generally have limited power to identify smaller but still clinically consequential increases in risk in adverse pregnancy outcomes or birth defects. This design is also frequently limited in its ability to control for confounders, and these studies are incredibly costly, both in time and financial expense to conduct. Another really important design that's been used historically is the case control design, and an example of this would be the CDC's National Birth Defects Prevention Study. And in this approach, pregnancies resulting in malformations are matched to control pregnancies where the infant is born without malformations. And then women are interviewed retrospectively about their pregnancy exposures, in some instances up to 2 years after the pregnancy. And they're asked to report what medications they took and when during pregnancy. And while we've learned a lot from case control designs, a major concern around the design is the potential for recall bias, the concern that patients who have an infant born with malformations may be more likely to remember certain exposures than pregnancies that were similarly exposed, but where the infant was born healthy. Because of the case control design, it can be used to estimate relative risks, but not risk differences, which is a really important measure in contextualizing the degree of risk and in weighing the risk benefits of using the medication during pregnancy. There's also frequently limited ability to control for confounders. They're limited to just what is collected in the data. And then very costly, again, in terms of expense and time in conducting these studies. So there's been growing interest in studying drug safety in pregnancy by conducting cohort studies nested in healthcare utilization data. And our group has been very involved in over the last decade in developing approaches to use these kinds of data in a robust manner for this purpose. For example, we've defined a cohort of approximately 3 million pregnancies where we have longitudinal information about the mother, claims from the mother's health records from throughout pregnancy, and then link those claims to the claims for the live-born infants using nationwide Medicaid data and the Medicaid analytic extract. And this data has really rich information on both inpatient and outpatient diagnoses, the conduct of laboratory studies, imaging services, surgical interventions, and really importantly for pharmacoepidemiology and the work that our group does, medication dispensing. So the advantages of this approach and using these data are the data sets tend to be very large. So we frequently have power to study relatively rare exposures and relatively rare outcomes like congenital malformations. The data sources are population-based, so there's not concern around selection bias. We have prospectively collected drug exposure information, so there's not the same vulnerability to recall bias. We have information on a wide range of confounders, and I'll say more about that when I get to my example. It's a very efficient design in terms of cost and time. Because of the longitudinal design, we can estimate both risk as well as risk differences. And then we can study multiple exposures in the form of medications and multiple outcomes, limited really only by what's coded with fidelity within the claims data. There are, however, really significant challenges that we have to be attentive to in our study design and analysis. When looking at outcomes, a single diagnostic claim does not necessarily indicate the presence of a condition. Claims are sometimes recorded to justify the performance of a diagnostic test. For example, there might be a claim for a cardiac malformation to justify the performance of a cardiac ultrasound in a newborn. So there's a need to define more complex algorithms using both diagnostic codes as well as relevant surgical and other procedures, and then a need to validate these algorithms. And our group has always taken the approach of defining algorithms and then validating them through the use of chart-based review. Exposure, in defining medication exposure, just because a medication was dispensed doesn't mean that it was necessarily used. And so there are a variety of different techniques we use to overcome that issue in terms of requiring multiple fills of the same medication on the assumption if a medication is being refilled, it's probably being taken as prescribed, or the use of more sophisticated epi methods like probabilistic bias analyses to account for exposure misclassification. There's also challenges in the confounders that are measured. There are limited information on some specific conditions like obesity, certain lifestyle factors, certain illicit exposures, and we work to overcome that through the generous inclusion of proxies for confounders or markers of their severity. For example, instead of just relying on coding of diabetes, we might look for the dispensing of anti-diabetic medications as an indication that the mother has diabetes. And then there's approaches that have been developed for modeling the potential impact of missing confounders to test whether missing confounders or poorly measured confounders might be impacting on the results. There's also limited information on non-live births. It's really challenging to study spontaneous abortions, terminations, and stillbirths in these data. So we typically do bias analyses to model the potential impact of differential non-live birth rates and see how robust our findings are to those missing data. However, with really careful attention to design, the use of these large databases can provide really important information regarding the safety of the medications in pregnancy. And we're seeing regulators increasingly both rely on studies using claims data in developing the labels for medications, as well as requiring claims-based studies for post-marketing surveillance of pregnancy safety. So I want to walk you through an example of a study published by our group looking at the safety of ondansetron and its association with congenital malformations using these approaches that I've just described. So by way of clinical background, nausea and vomiting are very common complications in early pregnancy, and early treatment of nausea and vomiting is recommended to provide both symptom relief as well as prevent progression to hyperemesis gravidarum, which can have serious health consequences for the mother. Ondansetron, which is a 5-HT3 receptor antagonist, is the most frequently prescribed drug for nausea and vomiting in pregnancy. This is a figure showing the rapid increase in the use of ondansetron in the Medicaid population. If you look at a commercially insured population, the rates of use are even higher. About a quarter of all commercially insured women in the US will be dispensed ondansetron during early pregnancy. And prior to our study, the available evidence on the safety of ondansetron was really quite limited and conflicting, with some studies suggesting no increase in the risk of birth defects, but the number of pregnant people in those studies was relatively small. The largest previously published study had just 1,233 exposed patients. Other studies, particularly coming out of the case control literature, suggested as much as a doubling in the risk of cleft palate and heart defects, although here, again, there are concerns about the potential for recall bias or residual confounding that could be driving some of those results. And guideline organizations like the American College of Obstetricians and Gynecologists had recommended further study. So this was our study published in JAMA back in 2018. The data source was the Medicaid analytic extract that I described before, nationwide Medicaid data. And at the time, the cohort size was about 1.8 million pregnant people, of whom 88,000 or so were exposed to ondansetron during the first trimester, the period of organogenesis. The outcomes that we looked at were congenital malformations. We defined 3 primary outcomes: cardiac malformations, oral clefts, based on the associations in prior literature, and then overall congenital malformations, and used algorithms that we had validated with and shown to have a high degree of specificity. And then to account for confounding, we defined a large number of covariates drawn from claims, including maternal demographics, a wide range of medical diagnoses, co-exposure to certain medications that themselves might be teratogenic, healthcare utilization as a proxy for overall health status. And the goal here in casting a really wide net was to have robust confounder control through the inclusion of a large number of proxies. So this just shows the covariates that were included. I think in total there were about 90 covariates that were ultimately integrated into a propensity score. So we had the domain of conditions associated with treatment indication, maternal demographics, maternal comorbid conditions, concomitant medications, and then general markers of burden of illness. And then in our analyses, we calculated adjusted relative risks using fine stratification on a propensity score, a data reduction technique used to create balance on all of the covariates that we included as potential confounders. At the first level, we adjusted just for the treatment indication and factors associated with the treatment indication. At the second level, all of our pre-specified confounders, and then at the third level, used an approach called high dimensional propensity score adjustment, which is a empirical, like machine learning type of method that empirically defines additional covariates or as confounders or proxies for confounders directly in the data. And then conducted a series of sensitivity analyses to test the robustness of our primary results, including the use of active comparators, comparing to other anti-nausea medications, redefining exposure based on 2 prescriptions for ondansetron during the first trimester, looking at a very narrow exposure window when oral clefts tend to occur in embryologic development, and then a negative control analysis where we looked at ondansetron exposure in late pregnancy. And here are our primary results. So you see 3 panels, the top panel, cardiac malformations, the second panel, oral clefts, and then the third panel, any congenital malformations. And as you can see, there was a crude association in the unadjusted analysis between ondansetron exposure and cardiac malformations, a 12% increase in the risk. However, when we fully adjusted for all confounders through the use of our pre-specified covariates, as well as those identified through high dimensional propensity score, the risk estimate shifted to the null, suggesting the crude association was confounded by maternal conditions and co-exposures, and that there was no causal effect. Likewise, when we looked at congenital malformations overall, there was a crude increase in risk that shifted to the null with adjustment. In contrast, when we looked at oral clefts, there was a 26% increase in the risk of oral clefts associated with ondansetron exposure, and this did not attenuate with adjustment for confounders, suggesting this may be a causal association. So our conclusion from the study, and these findings were robust to the range of sensitivity analyses that I described. After accounting for confounding conditions, we saw no evidence for an increase in the risk of major congenital malformations overall or cardiac malformations. And we found a small increase in the risk of oral clefts, but our risk estimate was smaller than previously suggested. We found a 25% increase in risk, which would translate to 3 additional cases of oral clefts for every 10,000 patients treated with ondansetron. So our interpretation of these data were that they were generally reassuring and that they suggested that some of the previously hypothesized associations with cardiac defects and malformations overall were not causal. And that overall our data pointed to the safety of the use of ondansetron during pregnancy. But interestingly, not long after we published our study, the European Medicine Agency required that all manufacturers of ondansetron in the European Union change the label of ondansetron, and you can see they cited our study, a cohort of 1.8 million pregnancies, and where we found an increase in the risk of oral clefts, 3 additional cases per 10,000 women treated. And then ultimately they concluded and made the label state that ondansetron should not be used in the first trimester. So this led to a great deal of concern on the part of patient advocacy and professional groups who noted that ondansetron is among the most effective antiemetics, and they made the point to the European Medicines Agency that this was an overstep, and but as of yet, the EMA has not changed its position on this statement. So I and the primary co-authors from the ondansetron study, Krista Hybrax and Sonia Hernandez-Diaz, wrote a viewpoint that was published in JAMA Pediatrics, where we took up this issue of ondansetron and the way the EMA had dealt with it, and we noted that in this perspective, as databases are increasingly used to study the safety of medications in pregnancy, it's likely that an increasing number of statistically significant but weak signals of elevated risk are likely to emerge. And I think the association with oral clefts is an example of that. And if regulators like the EMA fall into the trap of deciding whether a medication or a drug is safe based on statistical significance alone, it risks penalizing the most extensively studied drugs. There are a number of other antiemetics in pregnancy that don't have this warning, but in general, those have not been as robustly studied. So there's a need to consider the safety of alternative medications, as well as to consider the benefits of treatments. And our argument was that regulators should generally not respond by contraindicating these drugs, but rather work to communicate the risk to patients and clinicians and allow for deliberation about the risks and benefits for individual patients. There are many things that pregnant people do that are not completely safe, like getting in a car or other exposures that they may have in day-to-day life. And that doesn't mean we completely exclude patients from doing those things, but rather we'd ask them to have a rational consideration of the risks and benefits. And I think, this really leads to the challenge of, well, how do we communicate these risks in a way that's effective for providers and patients? And I think this is a really nice infographic. It was developed by investigators or clinicians at Rotunda Hospital in Dublin. where they show what the increase associated with ondansetron looks like. So on the top panel, you see the baseline rate of oral facial clefts in non-exposed populations, so 11 per 10,000 with that one dot shaded in. And then when you look at the increase associated with ondansetron, it's 14 per 10,000. So I think this is a very intuitive way, and I think we need a lot more work like this to better help us to summarize our data and communicate risks to patients in a way that they really can understand and help them make informative choices. So I'll close by just noting a few future directions or ongoing work. And I'd say at the outset here that I'm very open to collaborating and really excited about expanding my network of collaborators here at Stanford. We have ongoing funded work on opioids, opioid use disorder treatments, benzodiazepines, antibiotics, and antidiabetics. There are a lot of really important safety questions around these classes of medication in pregnancy, and a lot of work by our group to try to understand these risks. Neurodevelopmental and other long-term outcomes is another area of active interest. I continue to work very closely with Krista Heidrechts and Sonia Hernandez-Diaz, who I mentioned back at Harvard, and on these projects and understanding the impact of in utero exposure to psychotropics and other medications on conditions like autism or ADHD in the offspring. I'm very excited about the idea of looking at EHR-based data. I have started collaborating with Stephanie Leonard and looking at ways of using EHR data to bring in patient vital signs and laboratory data into our pharmacoepi studies. So really excited about that collaboration and that direction for work. There's a lot of strength in machine learning and artificial intelligence at Stanford, and Nima Agapur and I have started to talk about doing some work together, looking at using those methods to bring to large observational databases to look at medication safety. And then finally, I mentioned this issue around risk communication and risk summary. I think that's a really important frontier for pharmacoepi in pregnancy. We have lots of data coming out, but how that translates into clinical practice and how we explain what we're finding to patients and clinicians is going to be an important direction for us to make progress in the years ahead. So with that, I would just say again, thank you so much for the honor of being part of this symposium, and I look forward to the additional talks and to the breakout room and discussions. So thanks so much.
Great, Brian, thank you so much. Just as a reminder to everybody to please put questions in chat, and after we have the next two speed talks, then we're going to have all three speakers join us for a Q&A, which I'll moderate. But it is my pleasure next to introduce my partner in crime, Dr. Suzan Carmichael. Dr. Carmichael is a professor of pediatrics and obstetrics and gynecology at Stanford and is a perinatal epidemiologist. Her research focuses on understanding population scale drivers of severe maternal morbidity, including social and structural factors, quality of care, and chronic medical conditions.
All right, thank you, Deirdre. It's nice to be introduced, like, and sitting right next to you.
It's a new one for me too.
I feel like we should be doing a little podcast or something.
I know.
Okay, so sharing my screen. Don't start my 5 minutes yet.
Don't worry, we're on time. You got 30 extra seconds.
Okay, so where do I go to? Oh, back to PowerPoint. Slideshow. Oops. Do you know how to get to do slideshow?
I think you're good.
Oh, there we go.
Right there.
Thank you. Okay, great. All right. Let's start my timer.
It's okay.
Okay, you'll do it.
I'll do it.
All right. Well, thanks everybody for being here today. So I'm going to talk about one sort of approach to doing population-based studies of severe maternal morbidity. Okay. There we go. So just to make sure we're all on the same page, I'm just going to start with a brief definition and then why we study it. And then I'll talk mostly about how we're studying it. So in brief, if you think of for severe maternal morbidity, it represents the people who are most at risk of maternal death. And I've included a definition here. And basically the most common causes of this composite outcome are severe hemorrhage, sepsis, cardiovascular events, and hypertensive disorders. And then why do we study SMM? Well, it's about 50 to 100 times more common than maternal death. And so it's much more tractable and feasible to study at a population level. And like maternal death, it's increasing, has strong racial ethnic disparities, and shared common causes. And then how are we studying it? Well, I'm going to talk mostly about how we've been using this thing called linked birth cohort files, which I'll explain, and then a little bit about Medicaid claims data opportunities. So I'd like to note that most of our work has been in California so far, but in other states, it is possible to get this type of data. And I'd like to recognize the efforts of Karen Phibbs here at Stanford and Scott Lorch at University of Pennsylvania, who are basically developing a compendium of this type of data and harmonizing it so it can expand the way we do this work or where we do it beyond just California. So I know this is a busy slide, but the main takeaway I really want you to have is that the essential features of these linked birth cohort files is you start with, as we call them, is you start with the vital record, and then that is linked to the maternal and infant hospital discharge records at delivery. And so the vital record gives us sort of a population-based hub because it includes all births, so that's generalizable. And then the hospital discharge records are really important because they give us ICD codes, and that's how we can find the cases of severe maternal morbidity. Now, ideally, you might want more detail, like is it an EHR, but at a population scale, and do something like chart review, but at a population scale, that's not really typically possible. And then there are all sorts of opportunities that this opens up. There's an address in the vital record, and so that helps us study social determinants. I'll give an example of that. There are other linkage possibilities that we do in California, which include the ones noted here, which I'll give examples of, which are expanding beyond just delivery, hospitalization, linkage to antenatal and postpartum, and also data on repeat pregnancies. So first example I want to give is work from our colleagues at UC Berkeley, who are led by Mahassan Mujahid, a social epidemiologist there and close colleague, and just highlighting work by a couple of her PhD candidates. I'm highlighting these because they both have papers in press. So Sing Gao has a paper on redlining in SMM in press, and then Eleni has one looking at taking an intersectional lens to this and looking at that in the context of SMM. And she also has a review paper thinking about this conceptually that's in press. So hopefully those will all be available to people soon. And then also wanted to talk about with this address that's in the vital record, we can also look at things like environmental contaminants. So just wanted to feature the work here that's being led with Amy Padula, an epidemiologist at UCSF. And this is a supplement to her funding to look at wildfire exposure and preterm birth. So we're just going to basically bring in her exposure data into the linked birth cohort file so we can answer this question. And then here's an example of how we've used the linked data beyond just the delivery hospitalization. We just had a research letter published in the Green Journal, and you'll be familiar with our co-authors here. And basically, we looked at, if you don't just look at the birth hospitalization, how many cases can we find during the antenatal and postpartum hospitalizations? And basically, it increased the number of cases by 22.8%. And if we just look at non-transfusion SMM, which would be not including transfusion as an indicator in the index, it increased the number of cases by 45%, and most of those were sepsis. And then as an example of how we use the data on repeat pregnancies, I just wanted to feature briefly an article by PhD candidate in epidemiology, Shamali Bain, which she published last year. And this just shows you that the main finding here was that it showed that recurrence risk was 6 to 7-fold. So if you have SMM in a first pregnancy, you're at substantially increased risk in the next pregnancy. And then the final point I just wanted to make is to note that Medicaid data for California are being obtained through tireless efforts from the Center for Population Health Sciences, as well as other investigators on this call and other departments. And basically, this is going to give data on people who are covered by Medicaid for their pregnancy and for their delivery. And this covers over half of births in California. So it's not all births, but it is over half, and it covers most of the highest risk births. And these claims data are a little bit different, rich in a different way from the linked birth cohort file. They include inpatient and outpatient encounters, pharmacy data. They're going to be linked to vital record, and mom and baby claims are going to be linked to each other. And there will be a 9-digit zip, which again gives us that ability to look at social determinants. And that is where I will end. It was just a quick overview of some things we're doing, and I will stop there. And now back to Deirdre.
Great, thank you. Let me just adjust my screen here. So thank you. And again, a reminder to put your questions in chat. And next, it is my honor also to introduce Dr. Stephanie Leonard, who will talk about centering people who are LGBTQ+ in obstetrical research. Dr. Leonard, as you know, is an epidemiologist and an instructor in the Department of Obstetrics and Gynecology, Division of Maternal Fetal Medicine, and a faculty member within the California Maternal Quality Care Collaborative, or CMQCC. The overall goals of Stephanie's research, or goal, is to advance equitable, positive health experiences and outcomes for pregnant individuals. She is particularly interested in applying transdisciplinary, state-of-the-art methods to perinatal health research with a focus on pregnancy-related morbidities. Stephanie, we look forward to your talk.
Thank you so much. But sharing my screen?
Yeah, we can see it.
Okay, great. So I'm very happy to be here today. I'm presenting on behalf of our study team, which is led by Dr. Judo Obden-Malaver, who really wished to be here today but was unable to join. And this talk is about centering people who are LGBTQ+ in obstetrical research. And I'll just note we're using the word centering because, of course, people who are LGBTQ+ are in a lot of these epidemiological cohorts that have been discussed, but there's been extremely limited effort to identify and examine health outcomes and experiences among this population. I want to highlight that this work has been a collaboration between multiple groups here at Stanford, as well as elsewhere. And so to start, sexual and/or gender minority, or SGM, is a term that includes, but is not limited to, people who identify as LGBTQ, or lesbian, gay, bisexual, transgender, or queer. Approximately 7% of adults across the US identify as SGM, and that proportion has been increasing. Further, more than 1/3 of SGM adults in the US are parents, and many SGM people build their families through pregnancy and childbirth. It's well known that SGM people experience substantial health disparities. This includes elevated rates of hypertension, diabetes, and depression. Really quickly, I'm showing here a framework for seeing how these disparities are caused by dynamic interrelationships between societal, community, interpersonal, and individual factors. And it's really this framework and then some prior very limited data that informed a project that our team, led by Dr. Obden-Malaver, began in 2020. And I'm just going to highlight some of the main findings from that project so far. So we call this the Birth Certificate Project, and it was because in 2016, the California birth certificate was amended to include fields in which parents can specify their role as mother, father, or parent for the person giving birth and the non-birthing parent. The California Maternal Quality Care Collaborative has linked the birth certificate data to birth hospitalization data, and then our team leveraged these data to describe parental structures, as well as compare likely SGM parental structures with likely non-SGM parental structures. We've recently published a few papers resulting from this work. The first was a systematic review led by Ada Zhang, a Stanford medical student, on birth certificate policies in SGM families. Probably the main takeaway here is that in all but 3 states, the person giving birth to the child is assumed to be a cisgender woman, and this has major implications for SGM families. Further, no state birth certificate asks about sexual orientation or gender identity. In a second paper led by a resident at UCSF, Dr. Barahue, focused on examining SGM parental structures among California births. And I'd say a main takeaway from this was that SGM parents accounted for 6,800 live births in California over 5 years. which we also consider to be an underestimate. And just showing here the breakdown of all the different kind of combinations of parental structures, as well as some birthing parents on the left here. And then finally, we did an analysis that was outcomes focused about SGM disparities in obstetric and birth outcomes. And I'm showing the risk ratios here for mother-mother parental structures in comparison to mother-father parental structures. And you can see we really found some striking differences. For instance, the incidence of postpartum hemorrhage as well as severe morbidity were twice as high for mothers with mother partners as they were for mothers with father partners. And this was the first large population-based study about these outcomes among SGM folks. And with that, I was also just wanted to touch quickly on the PRIDE study. So Dr. Obden-Malver and Dr. Mitch Lunn here at Stanford are co-directors of the PRIDE study. This is the first long-term national health study of LGBTQ+ people, and it seeks to answer the primary question of how does being a sexual and or gender minority influence physical, mental, and social health. As I mentioned, the PRIDE study is national, it's an online, it's prospective, and it's longitudinal dynamic, and is made up of people who are adults and sexual gender minority in the US. As part of the larger PRIDE study, there's a current focus on family building among people who are SGM. The first question being about how the COVID pandemic has affected family building practices. That's been led by MFM fellow Ann Waldrop. Describing family formation patterns among sexual minority and gender minority parents, assessing relationships between health and parentage among SGM individuals, how parenting affects health, and identifying barriers and facilitators to family building. And with that, I just want to acknowledge all of our funding sources to make this possible. And thank you so much for your time. Here's both of our contact information. If you have any further thoughts or interest in collaborations, we'd love to hear from you.
Great. Stephanie, thank you so much. That was a wonderful presentation. I think all of these presentations, really underscore why we're here. I think you've all pointed out and highlighted areas where, data either haven't been good or lacking, and we certainly need a lot more. And so it's very exciting to see all of this work that's being done at Stanford. I'm going to start, Brian, with a question for you that's in chat from Ron Gibbs. Fascinating presentations. I think we all second that. With big data, how can we get around variability in clinical diagnoses such as sepsis? Here, there are varying definitions over time and maybe missing data such as PO2 sat. Thanks.
Yeah, no, it's a great question, and I guess I'll take it in two parts. So the issue around changes in diagnostic criteria over time is certainly a variable that you would want to include in your something you adjust for through propensity scores or straightforward adjustment methods to account for that. I think one of the focuses in the field has been really on defining algorithms that define outcomes with a high degree of specificity, a high positive predictive value, and that's really based on the principle that if you define an outcome with a high specificity, even at the cost of limited sensitivity, if the sensitivity is non-differential between the exposed and the unexposed, then your relative risk estimates will be unbiased. And so that's a lot of epi speak, but it's essentially if we can get to a definition where we're clear that what we're defining, for example, cardiac malformations in the infant, we might require an appropriate corrective surgery, or neural tube defects might require a certain type of surgical intervention. Then we can trust that our relative risk estimates are unbiased. Again, assuming the ascertainment is not differential between exposed and unexposed.
Great, thank you. And just a reminder for others to put questions into chat as they come. I have a question actually for you, Suzan. Some of us do quality work. Joint Commission requires that. I see Janine Johnson is on this call, and she really leads us in these chart reviews. And we always have the question of the numerator and denominator. So your postpartum readmission work is particularly exciting because I think there's a huge gap here, and I'm wondering if you can comment a little bit more on how accurate that is in terms of really understanding when we do these chart reviews, we see the charts of people who come in, but we don't know how many did not come in and how much that is an area that's, I think, increasingly recognized for the future as could potentially inform a lot of quality work. Can you comment a little bit on the quality of those data? And
sure. I think it has, all the issues that the birth hospitalization has as well, with these administrative data, as Brian has been addressing also. But I think the readmission itself is just as good a quality. I'm not sure why it wouldn't be. And the linkage, I don't know if you're like getting at like what are the linkage issues also, because the linkage is good for the mom.
Are you comfortable that we're capturing all of readmissions in this data set? Or for the most part.
In California, I believe that we are. And my understanding from the people the person who actually has developed the linkage methodologies, we do have really good identifiers for the mom, especially for readmissions, to ensure that those are like accurate as well. And we're a big state, so it's going to be a little bit different how these things work out in smaller states where people may be going across state lines to get care. Those are just some of the issues that come up for me. We also have the emergency department visit data, but what we don't have in this linked birth cohort file is outpatient data. So it's only ED or admission.
Is it only ED admission? Because I think that's where things break down, because we have people, when we're doing quality work, we want to know in the ED, did they do the right thing and admit the right people and send the right people home? And what you worry about is, do people come into the ED and EDs? I think our ED is excellent, but maybe a community ED, some other EDs that don't understand pregnancy or not asking, did this person recently have a baby? Sometimes treat as just a little hypertension, the person with a systolic pressure of 180, which in our world postpartum is really quite alarming. So,
so if it's an ED encounter that got registered, they didn't it didn't have to turn into an admission per se, so that would be included. Does that make sense?
Yeah.
So it's
helpful.
I think it's if there was an encounter in the ED, regardless of whether it resulted in admission, it would be linked.
Well, I'm glad there are lots of